So I hope you forget the previous presentation for the rest of the afternoon, and then because I will not be as entertaining as the previous speaker. It's just a boring talk by a statistician. When I asked in advance for a paper to review, and I got actually two papers, both by Andish and by Reineke. So they are related to their interest. And another thing that I probably did wrong compared to the slides that you saw previously is that I used a template that was offered by the SciOP, but nevertheless, I will try to do my best. I have no conflicts of interest to declare. That's one of the template slides, so I never have anything to declare. I have a disclosure, by the way. I'm not a pediatric oncologist nor a pharmacologist, and the papers are more related to that. So the first paper is about pharmacotyping in acute lymphoblastic leukemia. I think the papers have been shared, but no worries if you haven't read them, because I will discuss them briefly, and you'll always have the opportunity to look at them more in detail later on. So what's happening? Okay, well, a trick. So there are elements that contribute to more optimal and individualized treatment that have been developed over time, of course. And that is, of course, risk stratification by clinical factors like age and white blood cell count and cytogenetic abnormalities. In time, we also got genetic and molecular profiling. We have heard about that more in the first talk, actually, by Peter. And that led, of course, to targeted therapies that also got to more optimized treatment. And in the 90s, due to more accurate molecular profiling, we also got minimal residual disease as a tool in ALL for monitoring response. And more recently, there are quite some developments in pharmacogenomics or pharmacotyping or pharmacogenetics. And that basically, I mean, as you probably know better than I do, usually in the protocols, it's very rigid, the dosing and the timing of drugs. And at the same time, we know that it's very diverse. The responses of patients are very diverse. So there is something that we need to learn there about both the drugs and the sensitivity to drugs. And that probably has to do with the genetic makeup. And the individual genetic makeup is related to the molecular or to the transporters and drug metabolic enzymes, etc. So that all is related to the sensitivity to the treatment. And this paper that I will discuss goes into that. And then, of course, there are improvements in supportive care towards a more individualized approach. So the paper that was distributed is about a study from St. Jude. And as I said, I'm not a pharmacologist, and I discussed this paper together with a pharmacologist to prepare. And my conclusion will be milder than his conclusion. But what they did was quite impressive. They included 805 children in their studies, newly diagnosed ALL, and they produced cell lines of these primary ALL cells, and they looked at 18 drugs, the sensitivity to these 18 drugs ex vivo, and that was expressed in a lethal concentration, LC50 it's called. It's the dose required to kill 50% of leukemia cells, and of course that goes from 0 to to 1 if you normalize it, so that's the measure, the outcome measure. They also looked at 23 molecular subtypes, and they looked at the clinical results in these children. They looked at response measured by MRD and overall survival. And then they integrated this entirety of information, and that kind of constituted the pharmacogenetic landscape of these children with ALL. So this is what, and I will not discuss the statistical details. They are in the paper in Nature, and I think all of these methods are appropriate for the type of analysis that was required, so the kind of data and the outcomes. But I will go through the paper by looking at some of the figures, because the figures very well show you what they did and how they expressed the results. First, I start with a table. So they had these LC50 measurements, and they combined that with the clinical data. And this is the table that they created, and that is looking at the 18 drugs that they studied across those some of those clinical factors. So age, sex, white blood cell count, and NCI risk, and population and ancestry. And of course, what's happening now? Oh, that's only in my view here. So what they of course, this is 18 times 5 tests that you do. So they needed to correct for the p-value, because everybody by now probably knows that if you do run lots of tests and you have your alpha is inflated. I'm not sure what's happening here, but I'll check here. So you need to correct for this p-value, and they applied a type of measure. Probably everybody's known by now with the Bonferroni method of correction, but they used the Benjamin Hochberg procedure. Nothing very important, but just another way of correcting. And then what you see, for example, in this table is that a drug like prednisolone, there is a difference for children in LC50, so in the sensitivity to the drug for children less than 10 years of age or more than 10 years of age. And so in this table, there are a few of those drugs with a bold line or a bold element behind it. So asparagine is also related to age, the sensitivity, and then there are a few others. Not that many. There are nothing related to sex or population and ancestry, and a few related to the white blood cell count and the NCI risk group, that is, again, a combination of age and white blood cell count, so that is very much in line with this one. So that is the 18 drugs, the sensitivity to those 18 drugs ex vivo in relation to the clinical factors of these children. Then they also looked at the sensitivity across the molecular subtypes. So here, on the x-axis, you see the molecular subtypes, and again, on the y-axis, all the drugs. And what you see here is what we call a heat map. And of course, the LC50 is a distribution. And if it's if the tumor is more sensitive to the drug, it's blue, and if it's less, it's more resistant, less sensitive to the drug, it's going towards red. So you see here on the top there is more blue. Those are the drugs that are probably used more often in general. There are a couple of drugs that do not show any particular relation with any of the molecular subtypes. Those are the 4 that are indicated here by the square. But there are other drugs that really have a particular group that, does it show? Yeah. That is related to a particular molecular subtype. You can also look at it differently. For example, if you take something like venetoclax, then you see, and that is expressed in the table, I think it's in the annex, where it shows that hippopleurid is versus any other type is more sensitive to venetoclax. So you can also turn it around and look at, well, the drugs and then the subgroups in different ways. They also express this heat map in terms of Violin plots. That's what you see here, and a Violin plot is basically a kind of a box plot, and you all probably know the box plots where they aggregate information of the distribution into a median and then quartiles. So this box represents usually the 75% of the entire distribution, and then you have the minimum and maximum. The Violin plot is basically the same, where you also have the median indicated with the horizontal black line, but then as additional, you also get a kind of a distribution of this LC50 in this case around the median. So it's usually a little bit more informative about the distribution or the relation with the drug. In this case, you have to be careful because, for example, this comparison where, well, lots of still the individual points are part of the other distribution, and previous slide, yeah. This was in this heat plot, it was really blue and white, so really distinct. And if you look at the distribution, it's not that distinct. So this is also more informative in a way than the heat map. Heat map can be a bit crude in a way. Another warning for reading those kind of plots is that you get a distribution like this one, even with 3 patients. So you have 3 dots and it draws a kind of a distribution, which is, yeah, not entirely based on data then. So you have to be careful, and it's still significantly different, while all these 3 points are also kind of seen in the other distribution. But nevertheless, it's significant. And this also shows that, for example, this is a comparison of a group with 5 patients versus all 644 other kinds of molecular subtypes. So be careful in interpreting these kind of curves, but it is informative. This is, so we looked at the molecular subtypes in relation to the LC50 in ex vivo, and now we move on to the response in patients. The actual response measured by MRD, and they measured MRD at midpoint in the induction, and that is after 15 days or at 15 days MRD, and this is particularly the curve in B-cell ALL. And they also looked post-induction at 42 days. So they have quite some measurements. And this curve indicates, again, the sensitivity of a drug and what in relation to MRD and in relation to the response. And what it shows is that a change in a unit change in this coefficient corresponds to a unit change in MRD status, of course, all at a log scale. So a change of 10 corresponds to a change of 3, and a change of a coefficient of about 0.3 corresponds to a 2-fold increase in MRD. So what it shows is basically the relation of MRD and how well MRD corresponds basically to the sensitivity to the drug. And this is for BLL at 15 days, and the next curve is at 42 days. And what you see is still the same drugs are or the MRD is still as good as a prognosticator in relation to these drugs after post-hoc induction. There was also a clear difference in B-cell ALL compared to T-cell ALL, and that's probably known. So then they kind of took all the information together, and not all patients got all drugs, obviously, and so they had to impute lots of data here, and they also are honest about imputation, that it's kind of a way of accumulating data or inventing data in a way, but they did their best to validate the imputed data sets, and they didn't work with one imputed data set, but they made 10 data sets, and all in all they got a huge amount of data, and then they started looking at sensitivities of these drugs, and there is a way of clustering then the sensitivity among all the other information, and they came up with 6 clusters that they defined. They are, of course, and they are expressed here in terms of the constitution of molecular subtypes. And again, you can look at MRD, and so this is so they came up with kind of a new way of looking at ALL into groups of molecular subtypes. And again, you can then express these molecular subtypes also, or you can relate them to the survival of these patients, and that is shown in this curve. And they tested the difference, and this p-value basically means that there is a difference among any of these different clusters, whatever that means. I think this is really good for creating hypotheses and further exploration. So the overall impression, in my view, of this paper is that it is a very impressive study altogether. I mean, so much data of 805 children with newly diagnosed ALL, and so rich in, for example, the MRD measurements, but also with the creation of all the cell lines, and studying 18 drugs and 23 molecular subtypes. That's huge. That's enormous, and probably can only be done by an institute like St. Jude. And this comes partly also from the pharmacologists that I spoke with. They're not very subtle regarding drug concentrations. A drug that kills half of the cells in ex vivo may have very little to do with the drug that you actually give to children. I mean, a child is, of course, not. Well, there is this almost non-relation between cell lines and, of course, a complete body. So they didn't really look at actual concentrations that you give to children at all. So yeah, I mean, in that sense, it's a way of looking at it. Probably it tells you more that if a drug didn't kill any cell in the cell line, it's probably not very, it's probably doing not much, and I think that is a valid conclusion. The other way around is probably more difficult to draw, the other conclusion. Some drugs are unable to show sensitivity ex vivo. Methotrexate is, you need a whole set of enzymes to make it work actually, and it doesn't work ex vivo in a cell line. Probably organoids might be slightly better, but still it's very difficult for some drugs to represent the reality. And as the authors also conclude themselves, you cannot, this study didn't test combinations of drugs, and sometimes you know that you give certain drugs for their synergism, and that wasn't studied, of course, in this study. So, according to the pharmacologist said he was a bit surprised that it was published at all in Nature. I think it's good to. I'm interested to hear from Bob what his impression is on publishing such a study. I think it has to do with the entirety of what they did in such a large sample of patients. So my final conclusion is that it is a very nice approach for screening drugs especially, and it's definitely a basis for further exploration. Are there any questions so far about this paper in particular? Has anybody read the paper at all? I mean, no, nobody.
As you said, I think in the paper, in the discussion, because I did not go all through the results deeply, but they really went and said that it was indeed a basis for further exploration, and that they could not do much more with what they have, but that at the age of targeted therapies and everything, it becomes interesting to look further down at subgroups of leukemia. But indeed, they did not give an answer to all they found in the article. That's what I got from it. They're just saying we might look at subgroups. That was basically their message.
Yeah, and so also for me, I think it was a good paper to read. It's a different angle on therapy as well. But I think, as we spoke about earlier, maybe this also got published because of where it's coming from and some of the names on it. I think it was a good paper, but there's not much of a conclusion on it. It's not very novel results in that sense.
May I ask one question? It's a very big paper. I don't know. It was 45 pages, or I don't know. Do you think that the message of this paper could have been given in a much shorter way?
Yeah, that's a good question. I think what they nicely did is combining all these different aspects. I think they are all relevant in ALL. You can judge better than I do. There are quite some drugs being given to these patients in different settings, though, in ALL. The molecular subtypes are known and are also being used at different stages in ALL, I think. So, yeah, I mean, it is a way to combine all the information and to make it, to shorten it. I think it could have been better if they probably, yeah, well, I think this is a first approach, and then I think they should go into more detail or take a few drugs that are most prominent and then look into more detail and go again also take into account what is actually being used in ALL children. I mean, what you administer to children and what the relation is to these LC50s. So there is still, I mean, it's a good start. I think now, I hope that the authors will come up with more in-depth analysis.
Sorry, I've got nothing intellectual to add, but it's beautiful to see how you can display the same information using different plots and different ways to try and sell a different message. I particularly love the violin plots where you've got the little vase, and the person with the hooped see-through skirt. It's like histology, isn't it? The pathologist going, oh, this is a... And you go, it's a shark, isn't it? It's a shark. I think if you try, you can get every paper down to 140 characters. And this one says subtypes of ALL might respond differently.
True.
And then really, do you need any more? But one thing that I did years ago, okay, so do any of you know about Twitter, or has it all disappeared from your brains? Yeah, okay. So in the olden days, Twitter was only 140 characters and you couldn't put pictures on it. Yeah, I know, it's possibly before you were born. And in the journal, we tweeted the top 3 articles with 140 characters, no pictures, as a sort of a way of trying to engage people. And once you've started to do that, it's really, really depressing to read a full article, because you can more or less get most of what you need to know into a single sentence, just to crush everybody's 3,000-word articles there.
One last comment, and then we have to go. Oh, question.
Sorry, maybe I was completely wrong. I have just 2 comments. When reading the article, I thought about 2 things. One is just sometimes it might be that some drugs are unnecessary. That's all I thought about, like, oh shit, we're giving some drugs that are completely toxic and give no results. That was one key message that maybe is missing from their conclusions. And the other thing is, okay, so that's a very interesting paper, but my patience isn't altogether whatsoever. So what is it going to change? So, yeah, thank you.
Thank you for the last comment.
And the altogether is not in any contradiction with what was shown in the paper. Okay. So the next paper is coming from Reineke, actually, and as I said, I'm not a pediatrician, but this is about metastatic rhabdomyosarcoma, and especially the role of radiation therapy in these children and adolescents, by the way. And I had to dig into rhabdomyosarcoma myself a bit. So for those who aren't familiar with it, keep listening, and otherwise you can do something else. But soft tissue sarcoma is a malignant tumor that develops in soft tissue, as you would imagine. And there are many, many subtypes. WHO talks about 50 subtypes, but I've seen more subtypes being mentioned in soft tissue sarcoma. Rhabdomyosarcoma is the most common soft tissue and occurs specifically in skeletal muscle tissue and sometimes hollow organs, it says. And then again, rhabdomyosarcoma has subtypes, and embryonal RMS is the most common one, and then there is alveolar and a series of other subtypes beyond it. The prognosis of rhabdomyosarcoma is dependent on a whole lot of factors, among others age, tumor site, resectability of the tumor, tumor size, regional lymph node involvement, presence of metastasis, site and extent of metastasis, and biological and histological characteristics. Well, it's quite a lot, and that probably also explains why there are so many subtypes. It can also occur almost throughout the body. The prognosis of metastatic rhabdomyosarcoma is pretty poor. The event-free survival is less than 30%, 3 years, so it's poor. So this study used patients that were participating in a randomized controlled trial called the Burney trial, published. This trial included a patient with metastatic rhabdomyosarcoma and non-rhabdomyosarcoma soft cell tissue sarcoma, soft tissue cell sarcoma, or whatever. In that trial, patients were allocated to either chemotherapy, standard chemotherapy, let's say, or chemotherapy to which bevacizumab was added. And bevacizumab is a monoclonal antibody, in particular acting on VEGF vascular. Exactly. So VEGF, and so it's a targeted drug, and so patients were randomized and followed, and the results were, well, not very positive for bevacizumab. The result was that it was eventually a negative, not significantly different, didn't improve survival. Interestingly, there were two endpoints presented, or the same endpoint was presented, but assessed differently, either by an independent review committee on the left side, and when assessed by the investigator, was on the right side. Didn't matter much for the overall result, but it was quite interesting to see such a different outcome, or assessment. The Burney protocol said that radiation therapy was recommended between cycles 7 and 9 of induction chemotherapy to all sites of disease. So that where of course, whenever feasible. So actually, radiation therapy was recommended for basically all patients. So not all patients received radiation therapy. That is common practice, I would say. Patients received radiation therapy to none, some, or all disease sites, and it was either radical or not radical, if given. And unfortunately, the reason for the variation was not recorded. And the question to the audience is, what would be reasons for not giving a radiation therapy? Who? Any answers?
The age of the child, so usually less than 3 years.
Other suggestions?
So other local treatment to decide.
If the patient was in complete remission?
Site of the primary, if it's not eligible for radiotherapy.
So what would you advise then, when to give radiotherapy or not?
So as a local control, we can do surgery, resection as a local.
Patients that have a predisposition and they're not allowed to be radiated.
They're all metastatic. So maybe the extent of the disease. Not to do total body irradiation.
Yeah, so well, anyway, there are quite some reasons not to give radiotherapy, and they're all valid, I would say. And that is also what was shown in the paper, actually. So this is a table where you see the whether the patients received radical, partial, or no radiotherapy by some of the clinical factors, as you also mentioned. So, for example, the age is an important factor. Radical therapy was given to much younger children than partial or no radiotherapy. So if a child was older, then for some reason radiotherapy was less likely to be given. The number of metastatic lesions, as Reineke already said, was a factor that mattered. The metastatic sites also differed and was related to whether or not radiotherapy was given. And in the paper they also mentioned the Oberlin score, probably familiar to you or those that treat rhabdomyosarcoma. It's a score that includes the metastatic sites and lesions, and I think also age. It's a combination of things. But also there you see that if the Oberlin score was 0, 1, it was more likely to receive radical therapy, and if it was more than 2, then it was less likely to get radical therapy. So they also, and probably that's a known thing, that they also include whether whether the patient will benefit from this radical therapy or not. So the paper showed the results. These are the results. They did a landmark analysis, and probably you're familiar with the landmark analysis, but they only included patients that made it to day 221. That means that all patients should have had the opportunity to receive radiotherapy and shouldn't die or have relapses before, because then they wouldn't get this radiotherapy. So all patients needed to receive radiotherapy to reduce the risk of immortality bias. That is the thing. And so the first part is grayed out. They only lost 6 patients by applying this method, so that's not very serious in this case. And these are the results. So this is the curve for no radiotherapy versus radiotherapy, and what they, of course, would like to show is the fact that the patients receiving radiotherapy did better than those that didn't receive radiotherapy. But as we now know, or concluded just now, that there are quite some reasons why a patient got radiotherapy or didn't receive radiotherapy, and they're all relevant factors that have to do with the amount of disease or and so this could well be a curve probably for the Oberlin score, or for having 1 or more metastatic sites. Again, that would show that this is, for example, the curve with 1 metastatic site versus more than metastatic sites. So it's difficult to interpret these curves, I would say. They did a Cox proportion hazard model to adjust for all these factors, but as we learned in the first slide, there are an enormous number of factors that contribute to, or that are important in this kind of disease, and they included a whole lot of risk factors, like of course the bevacizumab treatment, the disease risk, and that is more or less the Oberlin score. I think the age, the histological type, and metastatic lesion count, so a whole lot of factors. And in that, it is important to realize that usually we say that, well, for every factor that you include in a Cox model, you need about 10 to 15 events. And in this whole bit, it's 80 patients, 85 patients. I counted, but they didn't mention it in the paper, but I think it's about 35 to 40 events. So that gives room for, let's say at most 4 factors. And that is 3 next to radiotherapy if you just say yes or no radiotherapy at all. So the model will not be very robust or reliable, I would say. So this is the conclusion that the authors drew themselves. They said, well, obviously, that it's not a randomized analysis, and it's unclear whether the improvement was related to positive effect of irradiation or a difference in the patient population who received the radiotherapy, which is a very valid conclusion to this end. So the risk factors were not balanced among the groups receiving radical, partial, no radiotherapy, and yeah, that can be very well explained. And then, so reasons for not incorporating radiation was next to the measured factors, I would say, are also the perceived feasibility, of course, concern regarding acute and late side effects. Those things were not even measured, and the uncertainty regarding the benefit that it provides. So lots of factors that were related to giving radiotherapy or not, partly measured, partly non-measured. So, and then the authors conclude that these findings still support routine use of radical treatment to the primary site. Not sure where they got that from. Radical irradiation to metastatic sites may improve further, may improve overall survival. Yeah, that's quite strong to say. I would say, based on these results, and the burden of such treatment should be balanced against prognosis, and further studies are needed. I like especially the last sentence, because I think that this is typically something that should be, should be followed by a randomized trial, and with all the difficulties that come with it, given the fact that it's not so straightforward to give radiotherapy in these cases, as we have seen. So, any questions about this study?
I have one remark. This is the reason I sent this paper, because there's so many post hoc analysis done every time there is a study running for a while, and then we make up another 50 papers to write down and draw very important conclusions of it. And I wonder, but that may be something that we discuss in the evening hours, because we have to move to your presentations, but I wonder if we should do these studies that we haven't defined in advance, and if we should draw any conclusions based on them, and if we should spend our time on it and take the effort of publishing them. But maybe that's something we can discuss in the hallways. But I see one remark, and then we go to your conclusion. Yeah.
I just wanted to make a remark on that. When I was reading the paper, I was hanging out with my family, and a lot of them have not studied at all. And I was showing them this Kaplan-Meier thing. I was like, which group would you want to be in? And just shortly explained what it is. And of course, they all wanted radical treatment. Apart from my grandma, who saw side effects in my grandpa, but everybody else was like, yeah, this one. And I think you're right. I mean, they wouldn't have Googled for it, to be fair, but there is people with a bit of a higher education level that might find it and draw conclusions themselves.
One question from me, because it was Reineke's paper, I did not read it in detail. Was there anyone with a bone or bone marrow metastasis surviving despite radical treatment, how it called this here? And what about and did they report on that, or did they write down what you have written here? That further studies are needed and so on.
No, I think
so
they mentioned bone metastasis in particular. Not so many patients with isolated bone metastasis, but I think they survived pretty well in these studies.
And there's a little detail that the Bernie was a pharma study, and it was scored according to RESIST, and they didn't have all the information on all the metastatic sites, because you only have target and non-target. So the radiation oncologists went back to the reports and tried to decipher if there was bone metastasis, but we're not completely sure.
Okay.